So we have a great session this morning. We're going to have talks by Thor Halfdanarson, Judy Golsch, Eugene Woltering, and Laura Tang, and then we'll have a break. I think we'll get started with Thor. Thor is a medical oncologist from the Mayo Clinic in Minnesota by way of Scottsdale and Iowa. Thor, are you around? There you are. Come on up. So Thor is going to talk about, he's going to give an overview on neuroendocrine tumors for us. And I do want to say, I want to express that, as a physician, that, it's really an honor to be able to participate in a group like NCAN. We as physicians, we have our own language. We talk in 3- and 4-syllable words, but it's really good to see the patients that, are what we're all about. And, as I was saying to Bob and Marianne last night, is like as individual physicians, we can only take care of a certain number of patients, but being in a big conference like this allows us to really get the word out to many more people than we can possibly see. And it is very gratifying for us to be able to kind of take what we've learned through medical school and practice and then educate you guys so you know more about your disease. And I think NCAN is just a wonderful organization for, making that happen. As you all know, neuroendocrine tumors, you've all had your personal journey and you've probably gotten about 5 or 6 different opinions along the way. And it's very difficult, even as a physician, and even more as a patient, to kind of sort through all that and to try to figure out what the right answer is. And even amongst us, Thor and I might give a different answer to the same question. So it's a very challenging area, but it's really gratifying for us to have the opportunity to try to, do our best to explain what we know about it to you guys. And we thank you for this opportunity. So without further ado, Thor.
Thank you very much. Thank you very much. So, thanks for the invitation. So, I was given the task of giving an overview of neuroendocrine tumors over 25 to 30 minutes. Actually, I think I would need more like 25 hours or even 24 days for that. But we will do our best. So what I thought I would do is just to quickly take you through some of the definitions, what are neuroendocrine tumors, and set the stage, hopefully, for some of the speakers that will follow later in the day. So let's just get started. So these are my disclosure slides. So the objectives are really simple. I wanted to ask a few questions, so including what are neuroendocrine tumors, how common are they, what are the symptoms, how are they diagnosed, how are they treated, why do we need better treatments, or are we fine as is, and then a little bit on what's on the horizon for therapy, because there's a lot of things going on with new drugs, with immunotherapy, that sort of stuff. But I also wanted to make sure that enough time was left for questions. So what are NETs? So NETs are malignancies. Essentially, they are cancers that they can arise almost anywhere in the human body. And they most commonly happen in the small intestines, in the lungs, pancreas, stomach, and rectum. But they can essentially start anywhere. I've always surprised that, like every year at least, I see a net that I have never seen before, and I probably see about 200 new nets a year. So they keep surprising you. And they are an extremely heterogeneous group of diseases, meaning that there are almost no 2 nets that are the same. And the presentation, the symptoms, and the treatment all differs greatly from one person to the next. So the first thing that we do when I see a new NET patient, so I always make sure that I have the diagnosis right. So the key is to get the pathologist to look at the slides, and we'll get into that here in a little bit. And then I want to have an idea about how this NET will behave in the coming years. And that's where we talk about tumor grade and differentiation. I was going to show you a little bit about that. So grade 1 tumors are generally very slow growing. They can sometimes, you can sometimes watch them for years without even doing anything, and they barely grow. And then on the other scale, we have the grade 3 tumors, which can be among the fastest growing malignancies in man, and need immediate therapy with chemotherapy, and can be incredibly hard to control. So tumor grade is really just a system to tell us how aggressive these tumors will be, and there's a number of ways to do that. So one is to stain the tumor for what's called Ki67 or MIP1, and you've all probably, or many of you have heard of that. And Dr. Tang will hopefully tell us a lot more about that, but this is sort of the simple oncology view of that process. So we just take a little bit of tissue, we stain it with that the Ki67 stain, and then we count the cells that are positive, and that gives us an idea about how aggressive the tumor is. And this really strongly predicts how the tumor will behave. You can have two tumors that look exactly the same on X-rays. If one is grade 1 and the other is grade 2, you know that they will behave very, very differently. So we'll probably see much prettier pictures from Dr. Tang, but this is just to give you an idea. So on the left-hand side, grade 1, you can see that there are very few cells that stain brown. So this is a low-grade tumor with less than 3% of the cells being positive. On the other hand, on the right side, we have a grade 3 tumor where most of the cells are staining brown, and this is the Ki67. So these are cells that are rapidly dividing or multiplying. So that's really what the stain is telling us. It stains the cells that are growing. So what about differentiation? So this is, again, sort of a simplification, but it works for me, and maybe it works for you too. So I think of differentiation as a different but very related thing to grade. And the reason I'm bringing this all up here is that you will hear this from your oncologist and from your team. They will talk about the grade and differentiation, and sometimes they will talk as if these were the same things when they really are not. And so this is really, the differentiation is really how much does the tumor resemble the tissue where it started from? And does it look well behaved? That's well differentiated, so all of the cells are sort of dull, bland, look the same, don't seem to be up to anything? Or does it look really aggressive, poorly differentiated, angry? And so I put this up there so it can look like a sloth, or it can look like a honey badger. And so these can actually be these cells. Like my wife, who's a pathologist, she says these are cells you don't want to meet in a dark alley. And so sometimes just by looking at this, you can see how aggressive it's going to be. And then to make it even more complicated, that not all grade 3 tumors, which is the highest grade, are badly behaved. Some of them are actually what's called well-differentiated grade 3 tumors, and they can behave much more like grade 2 tumors, and do need to be treated very, very differently from grade 3 tumors that are poorly differentiated. And this is what I see all the time, is that people who have new patients with grade 3 neuroendocrine tumors who've gotten chemotherapy that they probably never needed. And just because although the tumor is grade 3, the oncologist thought that this was a very aggressive tumor and needed to be treated very aggressively with chemotherapy. But when we look at the slides by a specialty net pathologist, they say, well, it's a well-differentiated tumor, and that chemotherapy, the aggressive chemotherapy, probably doesn't do a whole lot, and plus it's just very toxic. So moving on, stage is the other major determinant of prognosis. So stage is really the extent of the tumor. So is it localized or has it gone places? And stage 0, we don't really talk about that much in neuroendocrine tumor. Stage 1 is like really early stage tumor just in the lining of the small bowel. Stage 2 is a little larger, although it can grow through the wall of the small bowel. Stage 3 is generally in the lymph nodes. Let's say, for example, for the small bowel, it's in the lymph nodes adjacent to the small bowel. If it's in the pancreas, it's going into lymph nodes around the pancreas. And stage 4 is when it has really gone places, where it has gone to the liver, to the lungs, bones, or other organs. So that's stage 4. That's the highest stage. So I was going to spend a little bit of time on somatostatin receptors. Let me explain why I'm doing this, because I think this may set some of the stage for some of the other treatments that we will talk about later today. So this is probably the pinnacle of my artistic career, is that cell I made myself. And so I don't think I'm ever going to outdo that. And so this is that yellow thing there with the blue dots is supposed to be a cell, and neuroendocrine tumor cells. And you can see that on the surface of it, you have these blue dots, and these are the somatostatin receptors. And these are really a key player in most things in neuroendocrine. And we'll get it's a topic that's going to come up over and over again. They are present. They sit quietly on the surface of the neuroendocrine tumor cells, and they communicate with the inside of the cell. And why do we care about it? I'm going to show you in 4 slides, 3 or 4, why we do. And this is just another sort of close-up of the picture. You can see on the outside where it says SST, that's where the hormones bind to the receptors. The receptors goes right through the wall or the membrane of the cell, and it sends signals into the cell to do stuff. So it's present on almost all low-grade neuroendocrine tumor cells, not so much on high-grade neuroendocrine tumor cells, so I should probably change that. And low-grade neuroendocrine tumor cells, you will find them. So you can put what's called an antibody on there. You can stain them, almost as if you were painting them, stuff that sticks to the receptors. And then you can look at it in the microscope and see that the brownish island and that sea of blue stuff. These are neuroendocrine tumor cells, and you can actually stain them. You can see them. It gets even more cool. So you can take a picture of it with scans. You can put something that binds to the receptor, like a dotatate, and then you can put a little radio chemical called gallium-68 on it, and then you can take a picture of the entire body, and you can see that this is a gallium-68 PET, and you can see that everything that's red there, except the big red thing on the left side, that's his spleen, but then there are the kidneys, but you can see there are a lot of bone mets there. This is the same patient, just a different way of looking at the scan. You see all of those white spots all over the body. These are all metastases, and what we're doing, we're staining the somatostatin receptors with a radioactive chemical. Then we're taking a picture of the entire body, and we know exactly where the tumor is. So we can also target this for therapy. And again, we have our net cell there, we have the blue receptors, and then we have something that binds to the receptor, a somatostatin analog, which can either be octreotide or sandostatin, or lanreotide, somatoline. So both of them are very similar drugs. And they send a signal once you inject it into a patient that binds to the receptor, sends a signal into the cell that the cell should slow down, and it should stop making stuff that makes you sick. So like serotonin and hormones. And this can oftentimes keep the cells from growing for a long time. Okay, so most excitingly, and most recently, obviously, PRRT. We can again use the same receptor. Now, instead of using a gallium-68, we can bind to the receptor with dotatate and lutetium-177. And what I tell my patients sometimes, and I know this is maybe a little bit oversimplistic, I tell them we're going to inject you with a chemical that's recognizes these receptors, and it has a radioactivity on it. And the cells have the receptors. Think about these as 2 pieces of Velcro. When they come together, they're going to stick. And so that's how the gallium-68, or how the lutetium-177 dotatate sticks to these cells and then delivers radiation to that. We will hear much more about that later today, so I won't dwell on it. And I just put out these survival curves, which I'm not going to go into the details now, but we'll hear more about this later today. Okay, so how common are these? Is this really? Well, they're clearly very common because we have a lot of people here. And but if you look at it, the number of new cases per year is not that high, but the number of survivors is very high because patients generally live fairly long. And so we keep adding to the pool of neuroendocrine tumor patients, but they live very long. So if you look at the incidence, that's the number of new cases per 100,000, it's about 7. So that means essentially, if my math was right on the plane coming in yesterday, and there's a reason I went into medicine because I can't do math. And so 23,000 cases per year is the number I came up with roughly in the US. So that's not a huge number. There are 300,000 breast cancers and 150,000 colorectal cancers. So it's less, but because survival is long, there's a lot of survivors out there. And if you look at that graph, that orange line that keeps going up, that's the graph on the left-hand side. I'm not sure do I have a pointer here? Oh yeah, I do. Wow. So so if you see this here, clearly drank way too much coffee. And so if you go up, this here is in the 1970s here, and then. This is the number of new cases of neuroendocrine tumors, and as you can see, the number keeps rising for reasons we don't fully understand. And the blue line here is just other cancer. Oops, let's go back. So the blue line here is the number of other cancers, colon cancer, breast cancer. That has remained fairly stable, but the number of net cases keeps going up. Obviously, these 2 lines are on a very different scale because it's not like nets are more common than all other cancers combined. It's not like that, but it's just nets are becoming more common. Symptoms can be from the tumor itself. So these can be obstructive symptoms, such as a tumor that obstructs the small bowel and causes crampy abdominal pain or even obstruction. It can obstruct or block the bile ducts. It can block the windpipes in the lungs, causing cough or even coughing up blood or recurrent pneumonia. It can bleed both from the lungs. You can cough up blood then, or you can see blood in your stools. That's somewhat common. Tumor-related pain, oftentimes if there's a lot of tumors in the liver, that can cause a lot of pain. Or you can find a lump. I just saw a person last week or the week before that who just found a lump in her abdomen. It turned out to be a liver metastasis that was just poking out sort of out front and was very easy to feel. And then there can be non-specific symptoms, just feeling unwell, losing weight, that sort of stuff. So functional versus non-functional tumors, it's essentially a clinical diagnosis. We talk about this all the time. So the most commonly used definition of functional tumor is a tumor that produces hormones that result in symptoms. So if there are no symptoms of hormone production, we call it a non-functional tumor. You can have a tumor that makes hormones, but if you don't have symptoms, we call it non-functional. And those are the most common. So what are functional neuroendocrine tumors? Well, it's a fascinating group of tumors. Most commonly, carcinoid tumors that make serotonin, that will cause a lot of symptoms, such as diarrhea and flushing, which you all know, and even carcinoid heart disease. So there can be flushing, worsened by alcohol, exercise, emotional upset, diarrhea, carcinoid heart disease. Carcinoid crises, fortunately, are rare. I have not seen one in many, many, many years. And the hormonal symptoms, almost always pancreatic neuroendocrine tumors, although lung neuroendocrine tumors can do this too, low blood sugars, stomach ulcers, things of that nature. I just wanted to say that not all patients with carcinoid syndrome and worsening diarrhea have worsening carcinoid syndrome. Saw a patient yesterday. She just had her octreotide dose increased from 30 to 40 and had worsening diarrhea, and the thought was this was progressing disease. And with worsening carcinoid diarrhea, it just turned out to be steatorrhea. She was not digesting fat because we had kicked up the dose of the octreotide. Creon will take care of that. Okay, this is just the typical carcinoid flush. I lifted this from the Canadian Medical Journal. I like this picture because it's not as exaggerated as many other pictures are in medical textbooks. This is, I think, fairly typical for flushing. So how do we diagnose these tumors? It's a team effort. I can't emphasize enough that all things neuroendocrine are a team effort, and we need an experienced pathologist. We will hear from one later today. We need experienced radiologists and nuclear medicine physicians, and then obviously surgeons, gastroenterologists, pulmonary medicine, and a lot of other people. Endocrinology should be there. So we will hear a lot more about markers. Their opinions are divided on markers. I just going to put it out there. We will hear more about markers. I think markers generally have limited utility in the management of most patients with neuroendocrine tumors, but there are definitely exceptions where markers are greatly helpful. And markers are never sufficient to make the diagnosis, and there's not a perfect marker out there. I would love to have one, and what I wanted to point out as well is what I sometimes call a marker anxiety. So this is the anxiety that the fluctuating markers can cause, and especially if they're going up and down and there's nothing that we can see on the scans. We see this in all cancers that have tumor markers. We'll hear more about that here with the next speaker, I believe. Imaging, so I think we'll have a whole session about imaging, so I'm going to just skip through this. All I wanted to say is that octreoscans scans are on their way out. There is really not a reason to do an octreoscan scan today unless you absolutely cannot get a gallium-68 PET CT or PET MRI. So octreoscans scans are history. So why do we need better medical therapy? So essentially I need to justify my existence here as a medical oncologist or a chemotherapist, as I sometimes say. So that's because there are patients who have such advanced disease that even the best of surgeons cannot remove all of their cancer. And so this is one person who came to me 2 years ago with what was thought to be a localized small bowel neuroendocrine tumor, no, actually from an unknown primary, but he had liver metastases, and the thought was we could remove these liver metastases. So we did the gallium-68 dotatate, and as you can see, there's a lot of tumors. All of these white spots, all of these red spots here are tumors, and there is no way any surgeon can remove that, and we can't radiate all of that too. So this is where the medical oncologists like myself come in. So Does everyone need to be treated? Absolutely not. So there are patients where I observe patients with low-grade, grade 1, well-behaved neuroendocrine tumors with low tumor burden and no symptoms where I wait. And I sometimes wait and I wait. And like this person I saw many years ago with small biopsy-proven liver metastases, every year they grew by 1 millimeter, and he had absolutely no interest in going on any therapy. And they are probably about twice the size now as they were 3 or 4 years ago or 5 years ago. And to my knowledge, no therapy yet. So that it's probably the exception. But when your oncologist talks about possibly not treating, hear him or her out. There might be a good reason for it. So treatment considerations, why do we treat people? I always have to ask myself these questions when I see someone with a new neuroendocrine tumor diagnosis. There has to be a reason we treat people, not just because we can. And the reasons I say are really to relieve symptoms of carcinoid syndrome, functional pancreatic neuroendocrine tumors, bulky tumors or metastases causing pain, and to prolong survival. If I know that the treatment will prolong survival, essentially make a person live longer under these circumstances, I will offer therapy. And but keep in mind that a lot of treatments have not been shown in well-designed trials to prolong survival. A lot of surgeries have not been shown to prolong survival in large randomized trials, and we probably will never have those trials. And then you have to be mindful of treatment toxicities. And this is real. I have seen persons come in with leukemia from chemotherapy that they got for treatment for a neuroendocrine tumor that did not need to be treated with chemotherapy. So do not forget that each patient is unique and they differ greatly. One size does not fit all here. And the treatment of NETs is really a team effort. So let's talk a little bit, and I'm going to put a shameless plug in here for the NCCN, just a fair warning. So I'm a member of the NCCN Neuroendocrine Tumor Panel, and so I'm going to talk a little bit about that and NANET. So guidelines can be really helpful, especially for oncologists who are not very used to treating neuroendocrine tumor patients. So not everyone is like Dr. Howe and or Dr. Woltering or I and other speakers here today that see this day in, day out. So we have to have something that the general oncologist, who really has to know everything in oncology, can go by, because they cannot read everything that comes out in neuroendocrine tumors. I can't keep up with it, and they have to take care of breast cancer and colon cancer and lung cancer and whatnot. So they need, they really appreciate having good guidelines. And we fortunately have a few organizations, NCCN, and the NANETs, ENETs, COMNETs, and we'll hear some more about these possibly later today. And these are directed at trained professionals and not patients. So the very few very few guidelines have patient components to them. So NCCN does have patient guidelines, and I believe NCCN has a presence out there at one of the tables. And it would be super nice if NCCN had the guidelines for NET patients. They have guidelines for a lot of other patients, but fortunately, they are coming. So the NCCN NET guidelines for patients are in the works. They will be out hopefully later this year or early next year. So definitely keep an eye out on that, for that. So these are, so the NCCN, as I said, guidelines for oncologists out in the practice. I'm going to skip through this quickly. So this is really just to help oncologists in the community deliver the best possible care. And it really sets the standard in the US and actually outside of the US as well. And the insurance companies really go by this. And so just to let you know, there's a lot of work that goes into this. So in 2017, we estimated that we spent 31,000 hours on developing all of the guidelines. And there are many of them. There are 53 panels, and NET is only one of them. So there's a lot of people who give a lot of time for this. And it's a consensus based on multiple different specialties, and the patient guidelines are really based on the guidelines for physicians, and it's really to bring the providers and the patients on the same page. So here's where you can get these guidelines. If you're going to take a picture of a slide, this is a slide to take a picture of, and so nccn.org/patients. So treatment of symptoms, I think we'll skip quickly through this because we'll go back. And NCCN will have a presence out there. And NANET is coming out with a set of guidelines too, but not yet for patients. It's geared towards providers. So anyway, so treatment of symptoms, somatostatin analogs, as you all know, octreotide and lanreotide for diarrhea, telotristat, everolimus, chemotherapy, embolizations, and then treat the other diarrheas, the fat malabsorption, the bile acid malabsorption. I give a ton of creon and cholestyramine in my clinic, and sometimes with really amazing results. And then obviously not all treatments are drugs, because there is surgery, embolization, radiation, and so on and so forth. So for small bowel neuroendocrine tumors, somatostatin analogs are still the mainstay, octreotide and lanreotide, everolimus, chemotherapy, PRRT. And for pancreatic neuroendocrine tumors, they're a little different. I just wanted to tell you that they are different. They tend to be more aggressive with shorter survival generally, but they also respond much better to more treatment. So that's a good thing. We have many more options for pancreatic NETs than we have for small bowel NETs. So this is just to show the efficacy of CAPE-TEM, capecitabine temozolomide, in one of my patients. So you can see here a lot of these white spots on the liver. These are all liver metastases, and after 4 months of CAPE-TEM, these are all much smaller, sometimes even to the point where we can surgically remove them. So what's on the horizon? We're really winding down here. And I think I only have one slide here. So I think we're at the end of the road with conventional chemotherapy, somatostatin analog therapy. I think in the future we'll be looking more at immunotherapy or targeted therapy or combination thereof. There are definitely a few attractive targets. Formation of new blood vessels is one that we have been exploring, and then targeting the sort of the machinery within the tumor cells, like everolimus or Afinitor, those kinds of drugs. Your own immune system. So rev up your own immune system we can do that with medications. We can really rev up the immune system, so almost as if we were training it to see cancer cells and go after them. For neuroendocrine tumors, this is not working well, and so there are some promising leads there, but in general, especially for the higher grade neuroendocrine tumors, it's been fairly disappointing. There is a trial that will be reported at the meeting in Europe next month. We're all really excited to hear what that says. So definitely keep your eyes out for that one. And then what about if we combine chemotherapy with PRRT or immunotherapy with PRRT? This is really exciting. So those of you who follow the lung cancer, if any here, there was a big study presented last week, last week I believe, at the big lung cancer meeting, where combining immunotherapy and chemotherapy was actually better than chemotherapy alone. So I think this may be something that we will be. Oops, that tells me I'm almost over here. And so it tells me that we should explore those options. So how do we sequence therapy? I think I'm going to stop here, and I have a few more slides on how we sequence therapy. I think. Are we good on time? Okay, so I'll drone on here, and this is I just wanted to bring this up here because I get a lot of questions about this. How do we sequence therapy? My doctor said now that I was on octreotide and lanreotide, we should be doing this or we should be doing that next, and they come to me and say, well, is this the right thing to do? And so the sequencing depends on a number of factors, and with the sequencing I mean, what do we start with? What do we do next? What do we do after that? And it's the location of the primary tumor. Pancreatic tumors are treated very differently than small bowel neuroendocrine tumors. Presence of symptoms, things like that. The patient preference, some would prefer a pill. Others might prefer an injection or an infusion or something that's a little bit less cumbersome. And things like insurance approvals, co-payments play into this. And then presence of other illnesses. For example, if someone has really poorly controlled diabetes, then Afinitor or everolimus may not be the best initial drug. We may end up using it anyway. Same thing with sunitinib. If you have poorly controlled high blood pressure, then sunitinib may not be the best drug for you. And so I just made these here for the small bowel. So these are, I'm going to walk you through these. These slides have like a lot of components. So you could take, if you're going to take a picture of it, sort of at the end of the slide when it's all filled in, you can do that. And so this is the old sequence of systemic therapy. We started with somatostatin analogs, usually octreotide or lanreotide, went on to everolimus or Afinitor. Then some other treatments, and that could be, and anywhere along the line we could fit in embolization or surgery and those things. I'm just talking as a chemotherapist or a medical oncologist here. And then we referred people to Europe for PRRT. So this is how we used to do this. So this is what I suggest is the most commonly used current therapy. So we start with somatostatin analogs. Keep in mind you can observe some without therapy. And then upon progression, if we cannot deal with it with surgery, ablation, or embolization, we should move on to PRRT, which is now available and widely used. And then beyond that, everolimus. We may at some point talk about treating patients again with PRRT. We don't have a lot of data on it yet. And then other clinical trials, possibly immunotherapy and whatnot. So now that slide is complete. So if you want to take a picture of it, now is the time. So moving on. All right, did you get it? So for pancreatic neuroendocrine tumors, a little bit more complicated. So no or minimal symptoms. So you can either observe, which I don't do a lot of in pancreatic neuroendocrine tumors because they tend to be a little bit more aggressive, but I sometimes do. So start with somatostatin analogs, as you do for the others, and then upon progression, you actually have three options. You can do PRT, sunitinib, or everolimus. They have never been compared. I think you need to sit down with a patient and you need to explain to them the pros and cons of each therapy. And this is an informed decision that we have to make as a group. And then upon progression, you just switch things around a little bit. So you can, if you started with PRT, you can go with everolimus next or sunitinib, and then capecitabine temozolomide. And then we have other treatments. So this is for no or minimal symptoms. If there are hormonal symptoms, we have to treat that obviously with somatostatin analogs. These are the patients we tend to do embolizations on because that works really well for those kinds of symptoms. And then CAPTEM I find somewhat helpful in controlling hormonal symptoms in patients with advanced pancreatic neuroendocrine tumors. And then we have the everolimus or sunitinib and PRRT as before. And then other treatments down the road. So for those with symptoms from tumor bulk, so bulky, painful tumors that just hurt, big livers that hurt. So here I would start with CAPTEM. It really works. It's in terms of shrinking tumors, anywhere from 30 to 70%, depending on which study you look at. Capecitabine and temozolomide is definitely more effective than temozolomide alone. That was shown in a clinical trial this year. And then PRRT actually does shrink these tumors. Up to 35% of them have notable shrinkage. And then we have all of these other chemotherapies, and then the other drugs that we have mentioned before, the everolimus, the sunitinib, and so on and so forth. And then clinical trials. And at any time, if you have an exciting clinical trial, you can move the clinical trial up sooner. We are opening up a number of clinical trials now at Mayo, and we're going to be offering them anywhere along, usually after the first-line therapy of somatostatin analogs. I think we should offer clinical trials. So that's it. I have 6 seconds left. Thank you.